if each of you would just take 2 minutes and let us know who you are, what you've been doing the last 10 years, and just a general connection to what you're all about for the last 10 years. And you could go in any order, whoever wants to speak first, just speak out.
So for the alphabetically challenged person on my life, I'll speak out.
Yeah, go for it, Kim.
So 10 years ago, that was when I dipped out of my nuclear cardiology role and ended up chief of cardiology at Wayne State, where I could actually put Joel Kahn on the faculty.
Thank you, sir.
He was amazing preventive guy. What I basically did there at Wayne State and then going back to Rush University is inner city healthcare and specifically inner city cardiology. I talk about it incessantly that African Americans have the highest cardiovascular rate of mortality. And it has to do a lot with all of the social justice things you've been hearing, but it also has to do with diet and lifestyle. And these are the things that you may not be able to fix institutional racism and get the health literacy up all of a sudden and give everybody, college degrees when the educational system has been underfunded for generations. But you can fix the diet, and you can do that today if we all work hard enough. And so why do I, keep focusing on my Caucasian and wealthy population in Chicago as well, is because they're the ones who are paying for it. That is, not everybody understands that when an African American gets a stroke or heart failure or renal failure, goes on dialysis, and they automatically qualify for Medicare, and it's $86,751 per year. It's not the African American community that's paying for that. And so we all have to look at the issues that we have as a country, and it's our patriotic duty to improve our lifestyles collectively, and specifically those of us who are at the more difficult end. I think that's my 2 minutes. I have to yield to the floor.
Any order. Why don't you speak out when you're ready?
Go, Joel Fuhrman. You got the floor.
Hi, everybody. I became a family doctor with a specific intent to be taking care of people with nutritional methods. I'm very grateful for the last 30 years, having cared for tens of thousands of people with serious medical conditions, including thousands with advanced heart disease. And even though I'm not seeing patients at such a high rate anymore, I've spent a lot of time researching and writing most of the last 10 years. Still, my greatest personal satisfaction and pleasure comes from working with very sick people one-on-one and bringing them back to good health again. Right now, I have even today, for example, a person came into the retreat with a creatinine of 2.6, a hemoglobin A1C of 11.5. And after being in the hospital on 5 different blood pressure medications, he came here leaving straight from the hospital with a blood pressure of 220 over 110. They couldn't even bring it down. So not only did this individual get rid of his diabetes and high blood pressure and heart disease, but after he left our facility, within about 3 or 4 months later, his creatinine came down to 1.3 from 2.6. The first 2 months he was here, he still was running about 2.3, 2.4, but now his renal function went back to normal. I'm just giving that as an example, whether I'm caring for people with aortic stenosis who are refusing surgery, or people coming out in a hospital being urgently told by their cardiologist that they need urgent angioplasty or bypass surgery. Being able to actually have the decades of experience in being able to take these people, help them, and nurse them back to health is a blessing, and that I'm so grateful for, and gives me very tremendous satisfaction, even after more than 30 years in practice. So I really think that I made the right decision to sell my family's chain of shoe stores back in the 1970s and go back to medical school and do what I enjoy the most, and that's really working with people.
Dale, go ahead, sir. I'll go last.
Thank you, Joel. I'm Dale Bredesen. I'm a professor at UCLA. I was founding president of the Buck Institute for Research on Aging, and I've spent my career running a lab and looking at what causes the phenomenon of neurodegeneration. This is the area of greatest biomedical therapeutic failure. As people say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. So we started 30 years ago looking at what actually drives the process of neurodegeneration. What are the molecular drivers? And the big surprise after all the years of looking at this is that the science actually fits much better with an integrative medicine model, all of what's been talked about, and actually goes very much against the standard allopathic model of trying to treat Alzheimer's, which I think is one of the reasons that so many drug trials have failed. Over 400 drug trials have failed, billions of dollars. And so we reported the first reversals of cognitive decline back in 2014. We reported another 100 in 2018, and we've just completed the first clinical trial in which instead of looking at instead of looking at just a very small data set, you're looking at what actually drives the problem. And instead of just treating them with a drug, you're treating them with an integrative medicine approach, a precision medicine approach, dealing with the things because they are different for each person. And the results are unprecedented. We're just getting these published. We're very excited about these. Highly statistically significant improvements in multiple cognitive parameters. So again, I think the cardiologists have been great because they've actually been doing something that's been effective for years. We have not in the neurological community. We've not been able to do anything about these degenerative diseases. And I'm really excited about the possibility of taking these same principles and now applying them to others of these diseases. ALS, frontotemporal dementia, Lewy body dementia, just go right down the list. So I think this is a very, very exciting era in medicine, and especially in areas where there just hasn't been much in the past.
Thank you. I'll just say, Kim Williams, now that I can really see you close, you look so sexy without a beard. For an N95
well, this is COVID.
I mean,
It's COVID.
seriously, come back to Detroit, I'll set you up.
Well, I honestly had not seen my chin since I was 15, but being frontline in the ICU, the N95 won't work with a mask, so I had to shave.
And since half my patients now actually do mouth taping for better sleep, it doesn't work anyways. It's kind of an odd little, what's called the weird habit of better sleep. Take your mouth shut at night and you stop snoring and breathe through your nose, and you make nitric oxide in your nasal passageways. I don't know if you guys probably are aware of that, but it's very interesting. I'm in my 31st year of cardiology practice, but I'm in my 44th year of being a fully plant-based human. Age 18, I'm about to turn 62. I was a stentaholic, a stent addict. I had the pleasure of training with Bert Pitt at the University of Michigan. Academic people will know him, and Jim Willerson, who recently passed away in Texas, and then Jeff Hartzler, a world pioneer in interventional cardiology. But after 30 years of placing balloons and stents and all the other years being plant-based, I kind of threw the stent away and grabbed the sprouts and grabbed the broccoli, and have been a fully plant-forward but integrative cardiology clinic for about 6 years now in suburban Detroit. And it's just like we're all saying, whether you're dealing with kidney disease, as Joel Fuhrman, one of the legends, is talking about, or Dale Bredesen, the brain, or Kim Williams, really, just absolutely leading the academic charge in cardiology and bringing awareness to lifestyle. It's a system, it's a body. And anytime you deal with any of these issues, you're going to heal all the issues. And so I am, probably the happiest 62-year-old cardiologist in Detroit. I plan to practice, as all you pioneers are too, for a very long time, because it's so rewarding just to open the eyes and let people know about lifestyle and integrative options. It has to be science-based or it all falls apart and we all get criticized. But I think it's a great panel because we all try and stay rooted in the science, what I call the woo versus the science. And it's a fine line sometimes, but nobody does it better than really in my field and Dr. Williams bringing us back to guidelines. But I get beat up, sometimes sleep isn't in the guidelines, and we all know how fundamental sleep is for every disease we've talked about, but that's all right. Things will evolve and change and include some of these softer, lifestyle habits. But anyways, great to be here, Steve. Thank you.
So this is our 8th conference. Our conference is at 10 days, and people listen to panels and lectures, but really they're almost listening just to hope that I'm going to get the answer to this next question. This is the only question that the mainstream cares about, pretty much. We're not scientists. We're not that concerned with how things work. The only question anyone really wants to know is this question. And it's 3 questions. Anyone can answer it or answer the part that you want to answer. And I'm sorry to give you such a intense question, but this is the question. How do we prevent Alzheimer's? What contributes to it and what prevents it? How do we prevent heart disease? What contributes to it and what prevents it? How do we prevent cancer? What contributes to it and what prevents it? Anyone can answer any part of it.
Well, I guess I'll speak up again. It's rotating around to me, reverse alphabetical order almost. I would just defer to the wonderfully expert people we have on everything else, but I am one of the co-authors of, as Dr. Kahn was mentioning, our guidelines, American Heart Association, American College of Cardiology, for primary prevention of heart disease. And we basically focus on, the 7 issues. Are you smoking? Are you doing a good job of following your blood pressure? Know what your cholesterol is, blood sugar, and managing it, trying to get rid of it. Exercising enough. We focused, believe it or not, on aspirin. Put that in primary prevention because it's something that doesn't belong, that we had wrong for about 40 years. And unless your person is at high risk. So if you're interested in that one, just can look up #RethinkAspirin. We should be using a bit less for primary prevention. And then the cornerstone of it is nutrition. And if we are true to the literature, we're going to avoid the saturated fat, avoid cholesterol. We're avoiding sugar-sweetened beverages. Trans fats, fortunately, are illegal publicly in the United States and 3 other countries in the world, which is great. But if we are going to lower the sodium in the diet, we do these things, and the heart disease that has developed and is so ubiquitous in the United States, leading killer of Americans since, really since 1918, when the other pandemic took it out for a year. COVID, we thought it was going to take it out. The CDC says it didn't quite make it. And so heart disease was still #1 in 2020. We've got a major issue of this dual pandemic, and it's time to address it. So I would say the prevention of coronary disease, heart disease, heart failure, we have all the principles, and they're all in that document, but it's hard to summarize that in 2 minutes or less. But those are the major principles, and we could go a very far way of improving our healthcare finances, which is critical, particularly after COVID, when Medicare is going to go broke, and now in 2024 instead of 2026. So I'm telling everybody it's your patriotic duty to do the lifestyle things that we have outlined and decrease our healthcare costs.
I'm just going to piggyback for 2 vegan cardiologists, just a couple thoughts on heart disease, and we'll leave cancer and brain disease to the 2 experts. I mean, 1, get a home blood pressure cuff. I think, statistically, blood pressure is the biggest killer in the world, the global burden of disease study. And yet we have the worst mechanism of monitoring your blood pressure. You have to have a cuff, you have to use it, you have to relax, you have to do it 3 times. We need technology to deal with it. But at the meantime, go to the drugstore, buy a $39 blood pressure cuff. We make a big dent on health in America. Number 2, you can, for free in Cleveland and for $50 in Chicago and Detroit, get a heart calcium CT scan if you got some risk factors. If you knew you had heart disease, would you be motivated to follow the lifestyle that Dr. Williams has been writing about? So coronary artery calcium CT scanning for most, according to American Heart and new National Lipid Association guidelines, is taking a higher precedence. Something has been available for 30 years. But, we do colonoscopy, we do mammography, we do cancer skin checks. We don't do heart disease checks. We have the technology without injecting dye. The dye study is a much better study, but it's not really a screening study. And I think probably Dr. Williams would agree. And then finally, I'm a big fan. We have this thing called residual risk. You are actually doing the simple 7 of the American Heart Association, yet you have a heart attack. You probably should know your lipoprotein A, which is a particle in the blood at $20. You can measure, or your apolipoprotein B, $20 you can measure. A little technical, but we still got this group of people that on paper look pretty good and have events, and without a lot of expense, which is critical, as Dr. Williams just mentioned. We can just, up the game a little bit. They aren't yet in guidelines, but they have, thousands of peer-reviewed papers. So I go a little broader in my testing, always cognizant of patient costs, but, there's this lifestyle cost or, quality of life cost and burden of life cost and death cost. So Bob Harper, the famous fitness guru of The Biggest Loser show, brought a lot of attention to this genetic particle called lipoprotein A. And I know it's in European guidelines, it's not in American guidelines, but anyways, we have to always look for what's the next science-based addition to the armamentarium. But we're doing terrible at measuring blood pressure. So, we probably should do that first. Okay, got it.
Steve, is it okay if we stay on heart disease
Sure,
just for a moment.
sure. Go whatever you want.
Not a rebuttal.
It is still 2020. Who died most? Heart disease, cancer.
Exactly.
Number 3 was COVID, but it's still number 1. Yeah.
So just to respond, really, to Dr. Kahn, we did update the guidelines, and so now you have your new lipid guidelines, the prevention guidelines from 2019 and 2020. They're all saying that we do use LP(a), and we do use ApoB, and we do use coronary calcium scoring along with other measures of enhanced risk. So everybody should have the ASCVD risk calculator. You can get it online. You can put it on your phone. And if you're in that intermediate risk zone, do you really go on a statin? Do you really change your lifestyle? Hopefully you do the latter no matter what. But we actually use, there are 14 of them. They're looking at ankle brachial indices, as well as the tests that Dr. Kahn just mentioned. Those are our risk modifiers that if they are positive, then it pushes you toward more aggressive therapy. So they did finally make it into the guidelines. They are, in a narrow window for the people where it's not obvious. They haven't had a heart attack. They don't have extremely low risk. They're sort of in that intermediate zone. So we are employing them. And please, I'm sorry, go ahead.
No, I just going to tell you, in terms of access and equality and economics, you had a run in Detroit. I actually volunteered at a free women's clinic in Highland Park, Michigan, one of the most indigent, low-income areas. And Mitch Albom funds it. God bless Mitch Albom. And, I'm talking to a 62-year-old diabetic woman who's about 200 pounds. I mean, a nuclear stress test at $1,400 is not in her ability, but a $50 calcium CT scan at Harbor Hospital, Sonny Grace, is within her ability. So some of these technologies are definitive, and they include, not exclude, people that aren't traditionally getting really optimal medical care, which is really cool. Win-win everywhere. Yeah.
So the two last points I was going to make is, one is coronary calcium is critical. It's important to make sure that it's available. Unfortunately, in Chicago, we did a recent analysis and we submitted to publication. We're presenting it, I guess, in a couple of weeks at the American College of Cardiology, saying that if you're in a poorer neighborhood, the hospital near you does not have this available. And it's really something that we have to address. And one of the ways to address it, like you mentioned, Cleveland, they have it for free. In Texas, insurance pays for it. And so we've got to do something so that the people who are at risk and don't know that they have this, it's a test that has been shown to change physician behavior and patient behavior. And so getting this test out there in the public where it's available is really important. The last thing I want to highlight, double down on what you said about blood pressure and blood pressure measurement. Our 2017 guidelines, sure, we talk about office hypertension. Everybody knows about white coat office hypertension. What they don't understand is that in our inner cities, we have some people who are living alone, elderly, 85-year-old woman by herself in one of the neighborhoods that I grew up in, like Inglewood or Gresham in Chicago. There's gunfire. She's afraid. You put her in an office, and I'm 45 minutes behind, and she's comfortable, relaxed, nice environment, everyone being nice to her. Her blood pressure can be 30 millimeters lower in my office than it is at home. Wow. So that's in the 2017 guidelines. It's called masked uncontrolled hypertension. It may not be as frequent as office hypertension, but both of them are good reasons to do exactly what Dr. Kahn is saying. Do those blood pressures at home where they're actually meaningful.
Maybe I should chime in here. Thank you for my esteemed colleagues. I have a very different viewpoint than you two just expressed, even though I respect what you're doing on a societal basis. But I kind of don't agree with the emphasis. Right now, we have 89% of our population with this BMI above 25. We have fat on the body promotes both cancer and heart disease. We have an explosion of prediabetes. We have more than 60% of our elderly population with high blood pressure. I don't see the answer is what you guys are saying. We know that everybody that eats the American diet is going to develop heart disease, high blood pressure, be pre-diabetic, move towards increased risk of cancer. I mean, you can't achieve good health by checking blood pressures and medicating people. In fact, that is the problem. The problem is what the cardiologists and what the conventional cardiologists and other doctors have developed treatments for risk factors. They give you a drug to lower cholesterol, a drug to lower blood pressure, a drug to control your blood glucose. They think controlling these measurable risk factors is the way to control the risk of the population. And I'm saying it's really the emphasis is on the wrong syllable here. The point I'm making right now is your BMI, if you're a woman, is your BMI below 21? If you're a male, is a BMI below 22? Do you eat a diet of at least 95% whole plant foods? Do you put salt on your food? Do you exercise? In other words, is your lunch a large salad with a bowl of vegetable bean soup and a piece of fruit? I mean, what are we talking about measuring people's risk factors when they're eating themselves to death? And every person that eats that diet is going to develop abnormal risk factors and be fodder for the doctors to give them more medications and more medications. All I'm saying right now is these diseases that kill everybody and affect our whole population are not the inevitable consequence of aging. They're not predominantly genetic. We're not measuring people's risks. Almost nobody would have these risks. Less than 1 in 1,000 people would genetically need to measure lipoprotein A or allele 4 and things that would affect their ability to take extra drugs or extra something different. More than 999 out of 1,000 people, all they need to do is change their lifestyle, get rid of all their body fat. Males should have a body fat probably below 12.5%, and females probably below 23, 24%. I mean, in other words, let's focus on the issue here. Now, it's okay to be different, but I'm saying right now, I'm less concerned with all these testing. My starting point when a person comes to me is to begin by achieving their ideal weight. Whatever I'm measuring, blood pressure, cholesterol, sure, I'm going to wean them gradually off the medication. But those issues always resolve as they eat healthfully and lose weight. I'm not interested in measuring more and getting more data on them. I'm interested in making sure they're dropping at least 3 pounds a week. If they're not dropping at least 1 kilogram a week, they're not doing the right thing. We're talking about a complete overweight population that has to completely revisit the way they think about food. They can't eat anything close to the way other people eat. And if they're not losing weight each week, don't forget, insulin resistance is going to come down as people lose weight, but it improves just as they're dropping weight. And you drop more than 1 kilogram a week, you see improvements in insulin resistance. You see dropping at more than 1 kilogram a week, you see angiogenesis starts to go down and aromatase stimulation, high estrogen start to come down before the people lose all their whole weight. What I'm saying right now, the inflammatory markers, the high myeloperoxidase or oxidized LDL or HSCRP, these inflammatory markers start to go down, which really document a person's high risk of the cardiac event, start to decrease within a few weeks and even normalize while the person is overweight as long as they're dropping 2 or 3 pounds a week. Certainly if they're not going to lose that fast as they start to get closer to their ideal weight. But I'm much less focused on what's being discussed here, which I'm not against that for the general population. But our whole general population is eating a deadly diet that whether they have those risk factors or not are still going to likely have heart disease and cancer, even without those risk factor measurements. And if they don't have a high risk of heart disease, eating that way, they're going to develop a high risk of cancer and dementia anyway. So what's the point of focusing on one disease when they first have to focus on getting their health and their diet fixed and their weight fixed? And if you don't have that, you don't have anything, because there's no such thing as a healthy overweight person. Even if you medicated their glucose favorable, you got their blood pressure well controlled, you medicated their cholesterol down, and they're still overweight, they're still sickly, they're still at high risk of premature death, and they're still going to develop diseases. And the doctor is focusing on things they can treat instead of seeing, let's radically change the way people think about healthcare, think about their diet, and think about their own personal health. Because they don't first start at an ideal weight. What are we measuring? If you have a lot of body fat on your body, you have a lot of saturated fat on your body, and that saturated fat is still going to fuel oxidized LDL and cholesterol production. First, get thin. First, get rid of your body fat. First, get lean, get muscular, and get lean with plants. And make sure you're well nourished with all the nutrients people need. And then let's see if there's any residual risk. I've cared for thousands of people this way with advanced heart disease. Even people with low ejection fractions have their ejection, would build collateral circulation back and have the hibernating myocardium come back. And even my own father-in-law had a heart failure with a low ejection fraction. Now, 15 years later, his ejection fraction is normal. But I have so many people who've reversed calcified heart, reverse calcified valves, reverse congestive heart failure, got back ejection fraction, normalized kidney function. And so I'm saying is that radical nutrition is the starting place. The starting place is radical nutrition, not measuring people and doing more tests on them. Anyway, that's my 2 cents. Sorry to be so, passionately different.
So you're actually not, Dr. Fuhrman. I hope everyone is listening to what you said. Every ACC, I can proudly say, every ACC guideline since about 2017, including our hypertension one, has made exactly the points that you just made. That is, we start with lifestyle. We don't just pull out the statin at 7.5% 10-year risk. We do lifestyle first. We try to get the weight down. We try to get all of the risk factors down, and that means nutrition and exercise. I remember the trauma of publishing that document and having people say that we dropped the definition of hypertension from 140 to 130 so we could be in the pocket of industry. That just meant they didn't read the document. The document gave a list of non-pharmacologic therapies. And number one, just like you said, is losing weight. And we talked about cutting the alcohol, exercising with 3 different modalities, lower the sodium, increase the potassium, and do as much plants as you can on the diet. So every one of our documents makes exactly that point. And the 2019 prevention guideline I was talking about, the obesity section is actually the largest. That's the one with the most words in it, the most recommendations. And I'm hoping everybody takes exactly what you just said very seriously.
Thank you so much.
So I agree with very much of what Dr. Fuhrman said. And I think the point with respect to cognitive decline is that the arsenal, which we have been told is zero, that there's nothing you can do, and this has been printed by the Alzheimer's Association for years, there's nothing you can do to prevent, reverse, or delay the onset of Alzheimer's disease. And in fact, the opposite is the truth. There is a huge arsenal, and it starts with some of the things we've heard about: diet, exercise, sleep, stress, in this case, brain training, detoxification, and supplementation where appropriate. And so we've been interested, as I mentioned earlier, in the mechanisms. What are the molecules that actually drive this? Because it's been an area where there simply hasn't been success. Over 150,000 papers have been published over the years on Alzheimer's disease without a successful approach to it previously. So if you actually look at what's driving this, what we find again and again is it is anything that's producing inflammation. And there are all sorts of things from P. gingivalis from the oral microbiome to HSV from the lip to mold species that are in the sinuses. Pathologists find all of these in the brains of patients with Alzheimer's. So what we call Alzheimer's disease is actually a protective response to these various insults. And so you can look at inflammatory type Alzheimer's, which is what we call type 1. There is an atrophic type, which is reduction of support from trophic factors, hormones, or nutrients. There is a glycotoxic. People have talked about type 3 diabetes, and certainly insulin resistance is incredibly common, and it is an important contributor to Alzheimer's disease. And then there's what we call type 3, which is toxic. Whether you're exposed to metallotoxins or other inorganics. As a simple example, the people that were the first responders in the World Trade Center, by 2015, 13% of them already had cognitive decline. So any way that you're getting exposed, and here in California, the California fires are going to increase the likelihood. And of course, we're hearing a lot about COVID-19 and long haulers syndrome and brain fog and things like this. So we'll see over years, but it's likely that there will be an increased risk for cognitive decline there as well. Or whether you're talking about organic toxins, things like benzene and toluene and formaldehyde and glyphosate, or you're talking about biotoxins, things like trichothecenes. And as a classically trained neurologist and neuroscientist, I was surprised when it turned out that people were getting cognitive decline associated with these things that I had never been taught were related to cognitive decline. And then, of course, vascular disease, one of the most common contributors to cognitive decline. And finally, head trauma. So those are the 6 subtypes, and those are the things that are the major contributors. Now, what you can do about it, absolutely. I think the term radical nutrition that Joel just used, I think is a fabulous term. And we've followed his work for years, my wife and myself. So I think this is absolutely crucial. So many people have, if you look at what's actually happening in the brain of a patient with Alzheimer's, the misunderstanding about Alzheimer's has been that everybody wants it to be something simple. They say, oh, it's reactive oxygen species, it's misfolded proteins, it's a prion, it's on and on and on. And there are dozens and dozens of theories. At the heart of it, if you look at the molecular biology of this degenerative process, at the heart of this, it is an insufficiency. It's just that it's not a simple insufficiency like vitamin C. It is an insufficiency of the support of a neuroplasticity network that is critical for learning and memory. And so you have a whole set of things that you have to supply, and you have a whole set of things that represent demand. And everybody with Alzheimer's disease has more demand than supply. And therefore, you do need to change your diet. You do need to create insulin sensitivity. You do need to reduce inflammation. And there are excellent ways to do this. We heard earlier about a colonoscopy. Absolutely. We recommend that anyone who's 45 years of age or older get a cognoscopy. And that's relatively straightforward to do. There are some simple blood tests that will measure the very things I was just talking about. Measure things like your HSCRP and your HOMA-IR and your various mycotoxins and various organic toxins. These things are relatively straightforward to do, and then you can address those things. As a general rule, yes, absolutely. Diet, exercise, sleep, stress, brain training, appropriate supplementation, and detox. That's the way to go, those 7 things. But you can be much more specific if you actually look at where you stand with each of these, because this is the problem, of course, with chronic illness. By the time you get symptoms from chronic illnesses, you are most of the way through the pathophysiology. And that's been shown very nicely with longitudinal studies, PET scan studies, and cerebrospinal fluid studies to show that you get a diagnosis of Alzheimer's about 20 years after the pathophysiology can be shown to start. And that's just the stuff we can see. It's likely there's some micropathology going on. So this disease that we used to think of as a disease of our 60s, 70s, 80s, 90s is really a disease of our 30s, 40s, 50s, 60s that happens to get diagnosed 20 years later. So in fact, the same thing we're seeing with standard American diet and all these things is a major issue. Now I see there are a couple of comments about why we recommend what we recommend, and we can go into details. I know there's not enough time here at the moment, but we go to details about everything that we do. Part of what is critical in this insufficiency that we call Alzheimer's disease is that if you do a PET scan, you can see that there is decreased glucose utilization for at least 10 years before. In fact, people who have the most common risk factor, ApoE4, and let's talk about that for just a second, there are about 75 million Americans who have single copy ApoE4. If you have 0 copies, which is 3/4 of the population, your lifetime risk for Alzheimer's is about 9%. If you have a single copy, it's about 30%. If you have 2 copies, it's well over 50%. It's more likely that you will develop Alzheimer's, and that's 7 million Americans. So we firmly believe that Alzheimer's should be and can be today a rare disease, instead of what Professor Yaffe showed a few years ago, that it was the 3rd leading cause of death. Now, of course, COVID's knocked that out, so it may be the 4th leading cause of death right now, but it is a very, very common cause of death, costing the United States over $300 billion a year in healthcare. And as has been pointed out by Maria Shriver, 65% of Alzheimer's patients are women, 60% of caregivers are women. So in fact, this should be a rare disease. Now, the diet we have proposed is simply, again, because we've looked at over 5,000 people now who are on the protocol we developed. And those who you can basically get there dietarily from 2 ways. You have got to address this gap in metabolism. That's the problem. And Dr. Stephen Kinane showed years ago you can do this with ketones. So you actually see a decrease in glucose utilization in the temporal lobe and parietal lobe for virtually everybody with Alzheimer's disease. And yes, you can get at that with endogenous ketosis, great way to do it. You can be a vegetarian if you like. You can have some fish or some pastured, wild caught fish, especially smash fish, some pastured chicken and some grass-fed beef if you want to do that. Small amounts, no problem. And again, you want to be a vegetarian, no problem. The point is to direct the underlying biochemistry that we now understand much better than we did just a few years ago, that is actually required for meeting those synaptogenic demands. So you have, just as we know that osteoporosis is about osteoblastic signaling versus osteoclastic signaling, what we found in the laboratory is no different, that Alzheimer's disease is about synaptoblastic signaling being chronically exceeded by synaptoclastic signaling. So there are 4 basic parameters that derive this. One of them is anything that produces inflammation. You can follow the molecular pathways from NF-kappa B activation, inflammation, to activation of 2 proteases that give you the amyloid that collects in the brains of patients with Alzheimer's disease. So it's about inflammation, it's about toxicity, then it's about reduced energetics, and that is blood flow, oxygenation, ketosis, and mitochondrial function. And it's about trophic activity, estradiol, testosterone, vitamin D, all the things that are supportive. So the bottom line is this should be a rare disease. And doing the very things that you've heard from Dr. Fuhrman and Dr. Kahn and Dr. Williams will have tremendous impact on reducing the global burden of dementia. And that's our goal.
Dr. Bredesen, I know you're going to be leaving this panel early. Can you sum up everything you just said into a simple 1-minute version of what are the most specific action steps we should take to do, and what are the most specific action steps that we shouldn't do? I know that's just what you answered, but now Can you give us a super cliff note answer of specifically what are you saying are the actions we should take to do, and what should we avoid, as simple and direct for the general not scientific public?
Yeah, apologies that I have to leave for another meeting in a few minutes, but thank you again for the invitation. It's fantastic to be on with some of my heroes here. So the bottom line here is to recognize that this is the problem with Alzheimer's disease. And in fact, you can now evaluate what your risk is, just as you would get an advanced lipid profile. You can now get a profile to see where you stand with respect to cognitive decline. The brain is complicated, so you've got to know what your status with these various hormones and trophic factors and things are. But I would recommend that everybody who's 45 years of age or older, please get a cognoscopy and look to see where you stand. It's pretty easy, blood testing. As far as blood testing, I should say, and if you have symptoms, MRI and some simple online cognitive assessment, it's pretty easy to do. Now, Cliff Notes version of what to do would be, a mildly ketogenic, plant-rich, high-fiber diet. I would say not terribly different than what we've all learned from Dr. Fuhrman over the years, with appropriate fasting. And there's no question that again and again and again, we see that the people who do the best are getting themselves to be insulin sensitive, to be non-inflammatory, and to be in mild ketosis. And by that, I mean 1 to 4 millimolar beta hydroxybutyrate. If you want to check it by breathalyzer, you want to be acetone levels, 7 to 10 or higher. So that's the beginning. And then exercise is critical, again, for a number of reasons. Each of these things has multiple impacts. And then getting appropriate sleep. And many people have reduced oxygenation when they are sleeping and don't know it. Their doctors don't check it. It's absolutely crucial and a very common contributor to cognitive decline. And then stress levels. Stress is a huge issue. And in fact, just bumping up your cortisol is associated with a shrunken brain. So it is absolutely a critical contributor. And then, as I mentioned, doing some brain training, some stimulation is quite helpful. And then detoxification. Again, most of us have toxin levels we're not aware of. So getting detox, and even just starting with some basics like filtered water and high fiber diets and lots of crucifers and all these sorts of things, very, very helpful. And then appropriate supplementation. And again, this depends a little on where you stand, but those are the major ones. And so, Stephen, have I answered your question?
Yes.
Thank you.
Joel, Kahn, I just want to just shout in because there is more agreement, and there's no disagreement actually. But the very inexpensive or free test I mentioned, coronary artery calcium scoring, if you drop dead of a heart attack at 52, you don't have to worry about Alzheimer's dementia, which is really numerically make sure you know your heart status, and we can worry about your brain status at 50, 60, 70. But if you have a coronary artery calcium score of 0, 11 studies, including one just published about 2 months ago from the Netherlands, if you have a coronary artery calcium score of 0, you have a very healthy brain. If you have a coronary artery calcium score in the 99th percentile, you have a very unhealthy brain because oxidative stress, inflammation, nutrition, sleep, stress, environmental toxins, social factors all integrate in a very simple way that we can measure. It's not perfect, but it's close to perfect and quite inexpensive. So, there's unity in what we're saying. And all the therapies we talk about, radical nutrition addresses all the organ systems that we're dealing with.
Thanks, Joel. Maybe I can contribute a little bit here. Have my own way of seeing things. Just to bring things back down to specifics and specific recommendations and do's and don'ts is to review again that if you eat a conventional diet, you're destined, if you live long enough, to get demented, have memory loss, and develop some form of neurologic deficit with aging. If you don't, cancer or heart disease doesn't get you first. And I want to make it clear that we're saying that the diet that maximally slows aging and prevents cancer is also most effective to prevent heart disease and dementia. There's not one specific program for dementia that's different than the one that prevents heart disease and cancer. The anti-cancer diet, which lowers inflammation, improves immune function, is most effective to be dementia protective. So let me just say this clear, that white flour products and sugars and sweeteners, including honey and maple syrup, including bread and bagels and cookies and Fruit Loops and cold cereals and donuts and crackers and rice cakes and breakfast bars and chips, that all these foods of high glycemic carbohydrates people live on. More than half of the American diet is high glycemic processed carbohydrates that are linked to dementia and stroke and cancer. So being specific that you can't eat the way other Americans eat. And then Americans eat a ton of fried foods where you create more reactive oxygen species and inflammation. Sure, inflammation and toxins lead to cancer and dementia, but we have to stop eating things that cause us to be toxic. And particularly, we're talking about a diet rich in animal products also contributes to the toxic load, including microplastic, including glyphosate, including cadmium, including toxic metals. We're talking about a diet that's as animal products go up in the diet, invariably, so does toxic waste at the same time. We dump 1,000 tons of garbage into the oceans every hour. But the point I'm making right now is that we're looking at diets that maximally slow human lifespan and prevent all causes of death and disability. And we know that diets that promote ketosis may have some temporary benefits for certain conditions, but overall as a whole, ketosis-bearing diets lead to shorter lifespans and a higher cardiovascular deaths and a higher cancer deaths. Because when you restrict carbohydrates to get into ketosis, you usually have to include more animal fats and animal products to a point which has a more negative effect than any benefit moderate ketosis will give you. So I'm not encouraging, I'm saying there's no need to try to promote ketosis if your diet is already glycemically favorable, where your plant foods are whole plants, predominantly low glycemic carbohydrates like beans and quinoa and nuts and vegetables and eggplant and mushrooms. And when you're eating, the right type of plants, your diet is already glycemically favorable. It's true, some vegan or plant-based people are trying to restrict certain foods like nuts and making the diet too carbohydrate and too glycemically favorable. And you guys know a lot of plant-based vegans are eating a lot of white flour, white rice, white potato, eating a lot of high glycemic carbohydrates, and do not have a glycemically or nutritionally favorable diet. But that doesn't mean telling people to go into ketosis is the right answer. And if so, because we want to keep the diet, of course, as plant-based as possible, mostly vegan and animal products should be used as condiments or special occasion foods at the most, because they're linked with other problems with later life, including promoting excessive cancer growth, and because of their contribute to the toxic load the body has to bear with. Just wanted to add those couple of things.
And if I could just respond quickly here with respect to ketosis. So again, we're agnostic, whatever is going to help these people. As I mentioned earlier, the problem is that when they come in, and it may be that, Joel, what you're saying is the best way for prevention, great. But once the person is already having symptoms, the PET scan shows you have an energetic failure. You have to bridge that energetic gap. And yes, it's possible that you over the long haul could do this, but we consider this an emergency. When someone comes in, they're not able to metabolize enough glucose to keep their synapses going. Then time after time after time, there's just no question, getting some degree of ketosis helps their cognition. Now, perhaps the way to do it is to do it with exogenous ketones. Again, we're agnostic, whatever's going to help these people. But I think what you're saying makes a lot of sense for the prevention people. When we see someone with cognitive decline, either we're going to be successful or they're going to die. This is a terminal illness. And up until recently, it's 100% terminal. So far, what we found works best is to get them into some degree of ketosis. Now, maybe the way to go is to slowly get them off that over 6 months or a year after they've improved their cognition. Again, we're just looking at data. What actually helps this? So I'd love to talk to you further about how we might do this better and still get the right support for them. And we're going by Dr. Kinane's work showing that you can bridge that gap with sufficient ketosis.
It's NAD for these people who start cognitive decline?
Certainly NAD is helpful. I mean, and I should say, we're not recommending meat. We're talking about a plant-rich ketogenic diet. So, monounsaturates, polyunsaturates, that sort of thing. We're saying if you want to have some meat, fish, chicken, do it the appropriate way, do it in small amounts. But at the end of the day, this is a plant-rich ketogenic diet with appropriate fasting. That's what's worked best so far. And again, we're open. If anything is going to make these people still better, we're open to that.
No, I understand. And I use that, the fasting obviously too, but
yeah.
Well, it is, Neil Barnard just did a randomized study of the whole food, plant-based, naturally low-fat diet versus the Mediterranean diet. And there was, about 400 calorie difference. People had satiety on a whole food, plant-based diet. They didn't measure ketones by breath or blood or any other method. But when you're eating 1,700 versus 2,100 calories a day, you may well be in a more favorable ketotic or minimally ketotic state. That's a hypothesis because it wasn't measured, but it certainly was an interesting observation that people weren't hungry all day long, loading up on broccoli and Brussels sprouts and brown rice. It was quite the opposite. They were quite sated. I don't think.
And that's the paradox. And that's the paradox. These people are in an energy deficient state. We need to support them, whether it's with ketosis, whatever. We need to make them more insulin sensitive. And at the same time, you're right, we want to get them in a lower calorie diet. So that's the paradox.
Do you recommend any drugs for prevention of Alzheimer's, cancer, or heart disease? And then I guess the same question, what do you do? Do you recommend drugs if someone already has Alzheimer's, cancer, or heart disease? And you could include, and you could do this for heart disease and Alzheimer's and cancer, and you could talk about statins as well.
With respect to Alzheimer's, we don't recommend any drugs for prevention. And I think in the long run, it's possible that in a precision medicine approach we've taken, which addresses these different factors, will include drugs. And I think that's going to be the optimal way in the future. But right now, the Aricept, Namenda, the things that are being used have a minimal effect and can have some fairly negative side effects. So we use these quite judiciously.
And I guess you guys can also answer that question for heart disease. Do you recommend anything for prevention of heart disease? And what do you recommend if someone does have heart disease?
So for the very high risk people, we do recommend statins, but this area is changing, and it's changing in two different ways. One is the PCSK9 inhibitors are becoming a little bit more popular, a little less expensive. They seem to be tolerated better than statins. And they don't raise LP little a, which statins can do by up to 30%. So the next issue, though, but the statins do have a wonderful track record for prevention in the high-risk people, including secondary prevention. So I would say that there's another, keep your, nose to the grindstone, or ear to the ground, I should say, about the PCSK9 inhibitor out of Norway. I never mentioned brand name, so I'm not going to now. But once the FDA is able to get in there and inspect that facility, you'll have a PCSK9 inhibitor that will be injected twice per year. And that'll probably blow away all the statins, I would think. The other side of it is the diabetes drugs. And this is really something that I'm hoping every cardiologist is paying attention to. And that is the SGLT2 inhibitors and the GLP-1 agonists. These are like coming at us like a comet out of the sky. All of a sudden, they have cardiovascular outcomes of improvement of heart failure. There was an FDA approval yesterday for prevention of progression of chronic kidney disease with one of them, and heart attack, stroke, and death. And these, you see them on television, so I don't need to name any names, but these drugs are really amazing, and it's really game changer for people practicing cardiology who have not just high risk people, but people with active disease who have, and it seems to not matter whether the person is diabetic or not, that they end up with these dramatic improvements in outcome. So all of this is still being studied with multiple drugs, and we're going to, I think, see a sea change over the next 3 to 5 years, that if you are doing drug management, those drugs are probably going to change and include one of these used to be diabetes drugs. Now they're heart disease drugs. Love to hear either Joel's comment on this, but
yeah, nobody can summarize it better than you. Aspirin when appropriate, but we also know aspirin when not appropriate is a harm, but calcium scores that are high in coronary disease. But it's certainly not for everybody, and probably a whole food plant-based and diets all four of us would agree upon. I have some slight platelet anti-aggregate effect. I always love coenzyme Q10. It's the forgotten little portion of our Krebs cycle. It declines after age 40. It declines dramatically if you're on a statin. We've got a couple heart failure and longevity trials from international and from Sweden. So I throw that out there. It's pretty inexpensive, and but certainly not to the level of tens of thousands of people in studies. At some point, Steve Shore, because there's a chance to bring up extra virgin olive oil, I think it might be interesting before Dale leaves, because the plant-based community has had one perspective. Some of the most recent science in cognitive impairment has another perspective, but I'll just fish that for later on.
You could go ahead with that. Dale has left, so you go ahead with what you wanted to say about extra virgin olive oil.
Because there's now 2 or 3 randomized studies in mild cognitive impairment about higher doses of extra virgin olive oil. I think the Predimed study had a sub-study on cognitive impairment, extra virgin olive oil. Obviously, I'm from the tradition of a fan of Dr. Fuhrman, Dr. Esselstyn, Mr. Pritikin, Dr. Ornish, where for reversal studies, oils in general were largely recommended to be avoided or completely avoided. They know SOS, salt, oil, sugar diet, and I think when we're talking about soybean oil, corn oil, some of the poor quality industrial oils, that's probably reasonable. I don't know. I'm still split, between Robert Vogel's study on endothelial function, and there's one other like it showing some detriment in healthy volunteers. But from Spain, there was an 800 patient coronary artery disease study last year where they did unbelievable markers of endothelial performance, including this endothelial dust and endothelial progenitor cells and brachial forearm flow mediated dilatation. And a large amount of extra virgin olive oil actually was largely a benefit. Now, maybe you should just eat an olive instead of the oil and get the fiber and the full spectrum of nutrients. Maybe you should have a lyophilized capsule of an olive that really is devoid of any high fat content. But if Dale were around, I think his program, endorses extra virgin olive oil. It still remains one of those points that splits the plant-based medical community quite a bit. So I'll be quiet and throw it up to the rest.
Well, I don't see why any nutritional scientist has a controversy in knowing that and thinking just inherently that a walnut is better than walnut oil and a sesame seed is better than sesame oil and that a hemp seed is better than hemp seed oil. Because when you eat the whole food, you're not just ingesting lignins and phytochemicals and fibers, you're also getting nutrient fulfillment that reduces your apostat. And also these whole plant foods that contain the fats contain sterols and stanols that bind LDL in the digestive tract and have cholesterol moving from the bloodstream into the stool. What I'm saying is there's a host of different mechanisms via which the right type of fat in the diet increases absorption of phytochemicals and beneficial nutrients. And that getting your fat from a whole food like a walnut or a sun-dried olive or, using a whole food like that, there's other benefits you get to protect against cancer as well. So what I'm saying, you might see a short-term benefit from some anti-inflammatory effect of olive oil, but it's not going to have long-term. The extra olive oil is going to stop fat loss from the body because oil is such a concentrated fat source. It's absorbed so rapidly. It revs up fat storage biomechanisms and inhibits the rate at which you're losing fat from your body. So if you're a very slim person with a BMI of 19 and you're working 8 hours a day behind a plow in a field and you're a physical laborer with hardly no body fat, probably I have no strong admonition against that. But since the average American is already consuming between 400 and 600 calories from oil a day, and the average American is grossly overweight, even the people who are thinner overweight have too much fat on their body. Don't forget, it's only 2.4% of Americans that have a BMI below 23 because they exercise and they eat right. The rest of them are thin because they're alcoholics or smokers, or they have some disease keeping them thin. The 10% of the population that has a BMI below 23, the majority of those are sick people. So what I'm saying right now is that it's the logic and the science seems to generate the fact that sticking to your fat consumption coming from a whole food, because when you process it to an oil, it interferes with fat loss. And fat on the body is such a strong disease promoter that anything that prevents you from losing weight can't be overall ideal. So we have to put this in conjunction with getting adequate fat for maximized phytochemical absorption and adequate fat to stabilize heart arrhythmia and adequate fat and sterols and stanols and lignins to have the anti-cancer effects that those foods have without getting excess calories. And you can't do both. You can't have enough of the sterols and stanols and lignins and beneficial effects from walnuts and all these particular seeds and still have the caloric room in your daily pie to put oil in too, because your calories then be over your caloric requirements. You can't do both, the oil and the nuts. And clearly, even the Prevament study showed that when people got some benefit from even olive oil, when they switched to nuts, the benefits were more intense and more severe. Further reduction in heart attack rates. So that's why I'm an advocate where your source of fat comes from the whole nut, not from the oil, mostly because the people just don't successfully lose weight until they get the oil out.
Thank you.
I want to comment on Dr. Williams and Dr. Kahn. You had mentioned about the possibility of great new medical drugs in the future or possibly now. One of the things that some of our audience members are grappling with is that there's been a lot of information. There was a guy named Ben Goldacre, and he wrote a book called Bad Pharma, Pharma. And he went on and on and on explaining how a pharmaceutical company can do 25 trials and show you only the 2 that came out good. And the question is, when you get excited or feel good about a drug result, a prescription drug result, how do we know that it's unbiased, accurate, honest information and we're not being manipulated where they had 20 trials, they threw out the 18, they kept the 2, they stopped it after 6 weeks and didn't see what happened 5 years later. Like, I want to be open. I don't want to be only believe in natural stuff. I want to be open and also hear the best of modern medicine. But at the same time, these companies have been fined so many times. they're, according to this book, they're completely doing everything they can to get the clinical trials to look favorable. So when you see a favorable clinical trial, how do you say, okay, this is great, versus say, how do I know that this was the 1 out of 20 that they showed me and didn't show me the other 19?
So let me take that one on,
Yeah.
just because I have been a vocal advocate against the pharmaceutical industry, and it's totally about the pricing and profit margins, and the fact that we pay more in this country for drugs than any other developed country. They all have price controls and we don't. There's only 2 developed countries that don't. That's us and New Zealand. And New Zealand does so much with Australia that the prices are very similar. And Australia has price controls. But the issue that you're bringing up is an older issue. In my career, there have been a handful of drug withdrawals because they didn't do their job of finding out that cerevistatin that was would actually kill people with rhabdomyolysis if you mixed it with gemfibrozil. It only happened 35 times, but they pulled that drug off the market and it cost them dearly. Now, and going back even further, remember, the best diuretic ever, Celacrin. It was going to stop you from ever having to worry about uric acid. Well, all that uricasuria ended up with kidney stones and people getting into a lot. So they pulled that one off the market. So let me tell you, it's not in the drug company's best interest to do pseudoscience on 10,000 people and then apply it to a few million and get the lawsuits and everything else. So it still happens, but it happens very rarely. There's 2 double checks, not just the fact that the consumers and the lawyers are going to hold their feet to the fire. That's one. But I'd say the stronger one is the FDA's entire job. Now, you can argue about the FDA. I know there are people, particularly on the industry side, who think that they're too slow and they're too restrictive, and we have diseases to cure, and these folks have a drug and they won't approve it. And the manufacturing thing in inspection in Norway for inclisiran, people are pulling their hair out. So why can't we have this drug? Well, ever since the thalidomide was stopped by the FDA, and we didn't have those flipper babies in the United States, the FDA has really they were always doing it, but they sort of upregulated the level that you have to do to get through. And so they've denied a lot of drugs, and maybe some of those drugs would have been helpful and some of them could be dangerous. But the one thing that that book was not talking about is clinicaltrials.gov. It is relatively new, and so it may not have applied to the older studies. I have heard this over and over again, but usually it's about, sort of industry folks, not so much pharmaceuticals. When you do a large randomized trial for FDA approval, you have to register that thing. And you have, in order to get, you have to put in an NDA, a new drug application, get the FDA to approve the trial, and then you can't hide the results. In the past, you really could, but that shouldn't happen anymore. If it does, I'd like to know, just because, again, because of my anti-pharma bias based on the money, I would love to have some more things to talk about other than the money. So please tell me if I'm wrong about that, if I've got my head in the sand. But I think their feet are being held to the fire in several different directions, and I don't expect that we're going to have a bunch of dangerous drugs that are hurting people. You're always going to find something. The biggest exception I can say is the last 2 weeks, finding out that the incidence of COVID, not just illness, which is what the Pfizer and Moderna vaccines were actually approved for. And they were 94.5 and 95% effective at decreasing severe illness. Then you find out that was on like 40,000 people. And then you do it in millions, and you find out that the infection rate, not just illness, but infection rate is 0.04%. I've never seen that. It usually goes the other way around. You do your trial, you get your results, and then you apply it to real world, and it's worse. This time it's different. So I think they're doing it right. And I still am shocked that there was an article yesterday about 5,800 people having COVID illness. Some of them did pass away, 74 people, and specifically out of the 5,800 after vaccination. But this was in the context of like 96 million people in an active pandemic. So what I'm saying is that I think that the checks and balances that we have against my least favorite industry that says that safety is good, money, that's a totally different topic. Don't get me started.
Yeah, I'll just shoot in, Kim, you may not know this. My little tiny clinic in Detroit, we're involved with the same company that makes inclisiran, but we're doing the pelacarsen randomized study for lipoprotein A. It's my first really big drug trial in a long time. I have no love for pharmaceutical companies. I have no love. But the rigor with which we have to go through to enroll one person and the monitoring and the paperwork, I mean, it's what drives drug costs up insanely. But it's not fun to do drug trials, and you really need a whole team. The other part is the post-release follow-up. And, we learn things. We're learning about vaccinations. But, for example, the body of a drug called fluoroquinolone antibiotics. I mean, years ago, it was reported that these are like Cipro and Levaquin. I mean, very common, but that they might be associated with Achilles tendon rupture. But now in our field, Dr. Williams and I, aortic enlargement, aortic aneurysms, maybe mitral valve disease related to collagen interruption. So a drug that's out still needs active surveillance, still needs communication with the public about the risks. If you have a large aorta, you may be better off not treating your urinary tract infection with Cipro, and but that's a whole nother level of educating your patient population and the public about new data. So you have to keep the surveillance going long term, and treat naturally what you can treat naturally. And Joel, you look like you got wise comments here.
No, I'm nothing really. Okay. I'm still just eating my wild blueberries, my scallions, and my different mushrooms.
Different mushrooms. This is mushroom week. 45% reduction in cancer if you eat a variety of mushrooms during the week. Reported in the last 10 days, but reported many other times too. Yeah.
Okay, so during this conference, a lot of people have spoken about eating a whole food plant-based diet. I was listening to a Dr. Fuhrman lecture from somewhere, and he said something that caught my attention. He said that he has actually been treating some of the long-term vegans, that he has been doing this a long time, and he has experience with long-term vegans, which is probably the most interesting thing anyone could tell me, because there's nothing I want to know more than what happened to the long-term whole food plant-based diets. And I was concerned that I thought you said something to the effect that there was some concern about some of them doing certain things wrong and ending up with cognitive impairment or dementia. So I'm not sure that's what you said, but can you clarify, in your work with people that you consider long-term vegans, what has gone wrong? Have any of them gotten dementia or other things, and what did they do wrong? And could you tell us about that?
Yes, I do think I have a unique experience in that I've been, as a primary care physician, being the doctor for lots of people, especially elderly people, elderly vegans, for that community for decades, and seeing people to their ultimate demise and developing older and seeing what happens to them. I have huge clinical experience seeing hundreds of people a week. And as I mentioned earlier, many of my patients came from the early vegans, that when the vegan population in America just started in the American Vegan Society and the American Natural Hygiene Society in the 1950s, a lot of the physicians and gurus who were at the top of those people were my mentors. And I loved them, these people, and I looked up to them, and they were my friends. And most of them developed later stage Parkinson's and dementia. And when I had the availability to be their primary doctor, because I was younger, getting into my middle ages, and they were elderly and passing away, I found that the major issue was severe omega-3 deficiencies, where the DHA levels and the omega-3 index would be even non-existent, 0, 1, or 2. And so I'm saying that, looking at the evidence, that it's not just the toxicity and lack of phytochemicals and harmful. There's a lot of things that can cause Alzheimer's. And moving to a plant-based diet might reduce 95% of those Alzheimer's and dementia risks. But it thrusts into place a new risk of potential B12 deficiency that can cause dementia and severe DHA deficiency that can cause dementia and cognitive impairment and brain shrinkage. And studies do show that as the omega-3 index goes down, you see both shrinkage of the brain and cognitive impairment with aging. So my experience with scores of individuals, and by the way, there's not much studies on it, but there's animal studies in showing that DHA deficiency makes the brain more sensitized to the potential toxins that can cause Parkinson's disease. And I've seen an epidemic, a mini epidemic of Parkinson's in later life vegans, including, we're talking here about not junk food eating vegans. We're talking about these patients of mine and these people I respected and knew as advocates of natural hygiene who were living on a diet of fruits and vegetables and nuts and beans. They were eating super healthily. They weren't eating junk food and bagels and pasta and salad and oils, and they were eating a pretty healthy vegan diet. And I'm saying my evaluation, my experience, and the research I've looked at and looked into shows that there's a vast difference in individuals' ability to convert the ALA from walnuts and flax seeds into EPA and DHA, and that there's a wide genetic variability. And whether people are constricting fat and eating those omega-3, whether you're using more or eating less, there's some people are eating a diet. So in other words, what I'm saying, there's some nutritional gymnastics you can do to try to increase the conversion of ALA into EPA and DHA, but nevertheless, what I'm saying that the most overriding factors is individual genetic differences inhibiting some people's ability to make sufficient DHA and keep their omega-3 index above 5 as they age on a vegan diet, that all the nutritional gymnastics does not help, and that your people are putting themselves at some risk of dementia or even Parkinson's or other neurologic illnesses on a vegan diet if they don't look at trying to achieve a normal omega-3 index as part of the whole plant. And that's been too much ignored by people in this community. There's so much denial and religious ferocity of people just wanting to believe what they want to believe and not being conservative and cautious enough and making sure people have nutritional adequacy here. And my whole career, I've been suffering with this because these are people I really cared about and I took care of, and I was the primary care doctor. And I saw them get into trouble partially because I was not giving them, didn't know at that point in my career that omega-3 deficiency could lead to a later life problem on a plant-based diet. So I'm more cautious and conservative, obviously, now.
So how do you make sure that you get enough omega-3s? And you're saying omega-3 DHA. What are those the same thing? Are they different things?
No,
and how do you correct?
There can be short chain and long chain omega-3 fatty acids. And you can get adequate short chain omega-3 called ALA through flax seeds and walnuts and even green vegetables. So, and you have too much omega-6 fats especially from oils, it can interfere with the conversion enzymes. So you can't turn the short chain ALA first into EPA and then into DHA. You might convert about 5% of the ALA into EPA and about 1 or 2% into DHA. And some people's conversion may be sufficient to achieve an adequate amount and an adequate omega-3 index without supplementation. But my experience, my measuring of hundreds of people, the studies that I've been part of supporting all show that there's a huge genetic variability here. And for a long-term vegan to not supplement or not even check their level and to see where they run is somewhat irresponsible. Because these people that I'm saying that I followed and I was their primary care doctor for, they lived a long time. But what good is living a long time? Like Dr. Kahn said, if you're dead of a heart attack at 65, you're not going to worry about dementia. But since these people are not dying at 65 and they're living into their 85s, 90, 95 later years, then this becomes more of an issue because who wants to be alive through their 90s with cognitive impairment or Parkinson's? So we're trying to push the envelope of human longevity while at the same time assure people to have neurologic health in their later years.
Steve, I'll just add in, to answer your question specifically, there is a blood test, and Dr. Fuhrman's a frequent order, and I've been extremely frequent order, omega-3 index. There's another brand called Omega Check. It's relatively inexpensive. People can actually order it on their own. Now, there is no long-term evidence-based data. There is research, but that proves we should add that to the profile, and the U.S. Preventive Task Force hasn't added it to the profile. But you draw a few thousand of those, and you'll see meat eaters and plant eaters just uniformly. It's routine to see ultra low omega-3 blood levels, and whether that relies to brain levels isn't clear. I have a SNP. It's called FADS, fatty acid desaturase. I do not convert chia seeds over to EPA and DHA very efficiently. So I do supplement with a little bit of preformed algae-based EPA DHA, and I got my blood level up. I don't have a whole population of long-term vegans that have had dementia. Joel has a longer, experience in this than I have, but being concerned about your patient's global nutritional status, is appropriate for all of us, of course. Dr. Williams, you have thoughts? You're the king of nutrition.
I'm really just learning from you guys. You're way out of the cardiovascular arena. The only insights that I would give you about the cardiovascular system is the sort of strange things that have happened with fish oil and the heart with these trials blowing up. There apparently is not a lot of value. I still use them when the people have marked hypertriglyceridemia because I don't want them to get pancreatitis or, a small dense LDL issue. But for the cardiovascular system, we really have run aground essentially with multiple trials. The one trial that was positive where they isolated the EPA from the DHA, gave the EPA only, which Dr. Fuhrman just informed us would probably not be a good idea long term. That was a positive trial. And then subsequent omega-3 trials that had the combination said that the reason that was a positive trial is because they used placebo as mineral oil instead of corn oil, and that mineral oil was dyslipidemic and artificially increased the number of events in the placebo arm so that they could reach a statistical significance. So I think we have to admit that in cardiology, we really have not shown the benefit very clearly. But the brain health is another big deal.
And keep in mind that with these studies, these cardiologic studies are using fish oil and in pharmacologic concentrations that we're not really talking about here. The difference between using it to treat triglycerides, using it to have some pharmacologic effect. Here, we're just preventing a deficiency. I'm using much lower dosages. I think with almost any nutrient, taking too much of something and when you don't need it is not going to show benefit and could even potentially show harm. And being too low in vitamin D is not good if you're deficient. But you can supplement yourself to being too high, and that's not going to be good either. So it's the same thing with, so we're talking here about making sure people have nutritional adequacy, but not using these things as pharmacologic things to reduce or to change the symptoms of disease. We want to make sure nobody puts themselves into a long-term problem by being chronically deficient in something. And these studies are not studying vegan populations, and who are not eating. And some of the studies are done on people already eating a lot of preformed animal fats and EPA and DHA. The point I'm making here is when you isolate this data to a vegan population, then we see a much more broad spectrum of differences in both deficiency, adequacy, and excess. So we can be all over the place, but we see a much higher probability of deficiency. We saw about 60% of long-term vegans to have a omega-3 index below 4. About 60% had a level below 4, and ideally you probably want to be above 5.
I agree with that.
Okay, do you have pens and papers? I'd like to list 10 things, and then you could all either comment on each one or only the ones you want to comment on, and I will leave it to you to sort out how to communicate it. But I have 10 points that we'd like to get information from, and you guys can give us the information. So the first question that we're going to want of these 10 is which nutritional supplements, herbs, vitamins, minerals do you recommend? Which nutritional supplements, herbs, vitamins, minerals do you recommend? Number 2, what is your opinion about whole plant-based fats? That means avocados, olives, raw seeds, and raw nuts. That's what it means. Number 3, what is your thought about alcohol? Number 4, do you recommend bariatric surgery? Number 5, do you recommend a high sprout diet that Hippocrates recommends? Should that be our goal, to every lunch and dinner trying to have as much sprouted onion, clover, broccoli sprouts? Is that the ultimate goal? Number 6, should we be doing green vegetable juices and sprout juices? Is that the goal? Number 7, salt. Forget about bad salt, but what about like salts that they claim are healthier salts? Some people are saying that we need salt in our diet. Number 8, the new vegan burgers, the new popular brands of vegan burgers made from pea protein. Is this something you recommended? Number 9, phytochemicals. Joel Fuhrman said phytochemicals are nature's magic pills. What are phytochemicals? And number 10, Dr. Fuhrman has a phrase called G-bombs: greens, beans, onions, mushrooms, berries, seeds. What about whole grains? Why is whole grains, meaning quinoa, millet, amaranth, teff, buckwheat, wild rice, why are they not in the G-bombs? Aren't they a core part of our entire program? So if you would give us feedback on this, whatever you want to share with us in any order, just speak out when you're ready and comment on any of these so we can go through these 10 points.
Why don't we move around, but let me just address the G-bombs thing first, to put that aside, because that's something that an acronym I recommend. I'm not saying G-bombs are all people should eat. I've never said G-bombs is the diet I want people to follow. G-bombs is an acronym that identifies GBOMBS, 6 foods that have been shown to have powerful anti-cancer and longevity promoting benefits. There are other foods like tomatoes and things that aren't in the G-bombs that have plenty of anti-cancer and benefits. And it's not all the foods in the world that are good for you. It's just 6 top foods that I want people to try to include in their diet regularly, almost every day. It's not the entire dietary spectrum or dietary portfolio. There's plenty of additional healthy foods you can add to that. I'm just saying eat your G-bombs, eat other things too, but eat your G-bombs because those foods particularly have a lot of scientific evidence to slow the aging process, to prevent cancer cell replication, and to support optimal immune system. So I'm never saying don't eat other things that aren't on the G-bombs. There are plenty of other good foods too. There are carrots and there are beets and there are quinoa and there's other things. I'm not saying that's all you should eat, but I just utilize that G-bomb acronym so people keep in the forefront of their mind those foods I want them to include daily in their diet. So now we can move on to something else.
If I did a little marketing for you, I hope you don't mind. I added a little virtual.
Right.
Okay.
I'll take sprouts because I am a sprouter and I've read a lot, and I got a good friend, Doug Evans, who's got a hot book on sprouting. If we're talking again about economic parity and making nutrition available to all levels of society, you can get a mason jar with some holes in the top, get a few seeds, and for pennies a week, grow living food that's hyper nourishing. It's certainly not common, but it is available, and it would be a breakthrough. We don't want elite strategies. We don't want to have to go to the grocery store and buy a $10 container of sprouted radish seeds. You can do it at home. So, as many of us know, the broccoli sprouts have maybe 50 times the sulforaphane, the probably famous anti-cancer phytonutrient that broccoli has. And broccoli has a lot more than beef. Beef has none. But if you can learn to get a couple seeds and a little water and a little cloth and a couple holes in the top of a mason jar, you are on your way to, adding a lot of nutrition on a daily basis. So I would say thumbs up for sprouts.
But I have to add, Joel, that even though I do recommend and utilize sprouts and for their beneficial effects, but encouraging people to eat a diet of mostly sprouts and to
definitely not. Yeah.
On sprouts, it's not maintainable long term. People don't maintain that. So when people go on these extreme diets to that degree, they lose weight, they gain their weight back, they can't stick with it long term, and it's not even have the variety of foods you need for optimal health. So it's a great food, but not the idea that you should be on this sprout-based diet. You know what I mean?
Agree completely.
So why don't I just go in reverse order, Steve? I'm just going to give you bullet points on a handful of them because most of them are so far out of cardiology that I'm just interested in what the Joel Squared has to say about it. So for the G bombs and the question about whole grains, there is cardiovascular literature, and including the saying that these are very positive, that we should avoid refined grains, which has been brought up on this symposium already. And the Pure trial had a publication about 2 weeks ago distinguishing the increased death rate that happens with refined grains versus whole grains. When you are doing whole grains with all that fiber, it can actually change the microbiome. That's a word that we haven't talked much about today that probably we should all be talking about all the time, according to COVID mortality and neurologic degeneration. All sorts of things are related to the microbiome, including the cardiovascular risk factor, trimethylamine N oxide. So more grains would be better. And going backwards, skipping phytochemicals, talking about the new burgers, the one that I'm concerned about is heme iron. The NIH-AARP pointed out that that was one of the correlates with mortality. Now, when they were talking about animal products having heme iron, when you put it in a burger, it makes it taste more bloody, which makes it more attractive to meat eaters, granted. But if you tell me the saturated fat, cholesterol, TMAO, all from eating animal products are bad for you, and so is heme iron, I probably wouldn't try to go after that. But it may be that it's perfectly fine in the context of not all those other things that are in animal products. So I would say I probably wouldn't give that one a pass until there was enough data to say it was good. Salts, really important to understand that most of those salts are still sodium. Now, there are salt substitutes that are potassium. We have randomized trials in hypertension that potassium chloride will actually lower blood pressure. But if you take a Himalayan salt, a pink salt, it's still sodium. And so the sodium sensitive population, which tends to be hypertensive African Americans, probably should avoid it, at least be extremely observant if you're going to do that. The bariatric surgery one, there is definite cardiovascular benefit. Isn't it a shame, going back to what Dr. Fuhrman was saying earlier, isn't it a shame that you get to that point? Why can't we all get in a time machine, go back 30 years, change the diet, and not end up having to go on the knife? And Garth Davis, who's one of the prominent plant-based scientist, medical practitioner, is a bariatric surgeon, always talking about the benefits of it if he's backed into a corner, and we should do everything to avoid it. But there are cardiovascular benefits. The lipids go down, the cholesterol goes down, the blood pressure goes down, so your plaque development is going to improve. However, these people tend to gain weight. Again, they break through, which was also mentioned earlier. I have to comment on ethanol, just because there were so many people thinking that the resveratrol and red wine was going to save them and they could do just about anything they wanted. There was a little data out of Michigan State saying that cholesterol crystallization, when it gets a high concentration, is actually what breaks plaques. And the two ways of stopping that from happening were to use alcohol, and the other one was to, this is Georgia Bella, that those crystals that you can put them in your search engine, Georgia Bella cholesterol crystals, they are scary looking. To have that happen inside of a plaque, it's going to puncture the lining and it's going to give an acute coronary syndrome if that's true. So statins and alcohol were the way to stop this. Now, but that's in vitro. I think in vivo, we don't have any excuse. We don't have any great population, well done population science. And I'd love to hear if anybody else does it. But again, I have a conflict of interest there. I hate alcohol. I hate the taste of it. So therefore, I think it's not healthy. All right, last for me would be to comment on which supplement. You're going to hear a lot more from the other panelists, but I think that we have to recognize that B12, we only have three choices: eat an animal that ate the dirt, eat the dirt ourselves, or take a supplement. And I choose to take a supplement. And to remember that there one large trial. I think Joel was talking about this on his lecture the other day. That if you were a male over 60 and you take more than 55 micrograms per day and you're an ex-smoker, it increases your risk of lung cancer. So hopefully everybody's aware of that and they're not doing it. It's hard to find 55 micrograms of B12. You have to like take something and dilute it and take a sip or something. It's not easy.
I think, Dr. Williams, you pretty much ran down the list. We didn't talk about juice. I'm a big believer, as Dr. David Katz said, if not a green juice, what are you drinking? So if you're transitioning from Mountain Dew to a spinach, broccoli-based green juice, yes, you've thrown away the fiber, and none of us probably would recommend you throw away the fiber, but you've upgraded your health, and particularly, if it's, I just suggest a glass bottle because I hate BPA.
Plastic bottles.
All those xenoestrogens and air pollution.
Doesn't that look like it?
You know who took over your job was Dr. Brooks at University of Michigan, who's probably about the world expert on air pollution and cardiovascular disease. Not as much xenoestrogens and cardiovascular disease, but environmental factors matter. But I mean, a green juice with minimal sugar added, like a green apple, may not be a bad choice if you enjoy it. And if it's an alternative to some vice you had previously that upgraded it, I don't see a downside to it. Now, no doubt, store-bought juices and a lot of these chains that are doing smoothies that are largely sugar bombs should be, clearly avoided. But I wouldn't give, a Consumer Report total downer to a good green hair growing kind of juice that you've decided to add. Adding all that in, I don't think I have one a month personally, nor do I think I have one plant-based burger a month personally. Yeah, Joel.
I can tell you a little bit of my perspective too, is because I'm caring for people who have lupus, rheumatoid arthritis, psoriasis, other types of medical conditions and autoimmune conditions, including, inflammation from cardiovascular disease. And I have a lot of people who come to me because of gross obesity and food addiction. So what I'm saying, number one, is that with these autoimmune diseases, they become more active when their levels of carotenoid and phytochemicals are so low. And they inevitably are people who have daily headaches and they're weak and fatigued and they have pale looking skin, pasty skin. And I can feed them an ideal diet here at my facility, and it will take a certain degree of months for the level of nutrients in their tissues to get high enough, but I could accelerate the rate at which I get their tissue scores and inflammatory markers down by giving them a glass or two of juice a day, because their appetite is such where they can't take in all the vegetables and it would take too long to change the nutrient levels in their tissues. My measurements over a period of many years is it takes 9 to 12 months to bring the levels of nutrients in your tissues as high as they are in my skin and my body tissues. And we measure that with this laser skin carotenoid scanner. So what I'm saying, by adding the juicing, especially when I'm looking to a person's coming to reverse their lupus or their psoriasis, I can get their level of carotenoids and other nutrients higher in their tissues. And then I don't particularly need to juice every day, but I may have a glass of juice a few times a week. But the juices we use have 1 part carrot, beet, 1 part lettuce, celery, cucumber, and 1 part cruciferous, like bok choy, cabbage, kale. And we use that mostly as an adjunctive nutrient when people with an autoimmune disease, because I find I can get them to get better faster, get the inflammation down, get their psoriasis, get their lupus to improve faster when we incorporate the juices as part of the program. All the other parts, of course, are equally important. The other issue is that I take care of a lot of patients that weigh between 350 and 400 pounds. And some of these people failed gastric bypass. But the point I'm making here is that most of my frustration and sorrow across most of my career is taking people that you've seen, you guys know, you see people with diabetes, with heart disease, obesity, and you know you could help them, and you can't, because they're so food addicted and their home environment is so negative and their attitudes are so negative, and whatever it is, they're so addicted, you can't seem to get them to follow the program strictly enough to get to save their lives. And that's always been a frustration, how difficult it is to get some people to do the necessary changes they need to make. But what I'm seeing and what I've developed is the ability to take these people into my care, into a facility for 3 to 4 months, just like a drug rehab or a cocaine facility, where you're able to treat them not just nutritionally with a time of abstinence away from their food triggers, but also psychologically, to make them see the world in a more favorable, optimistic way, to improve their self-esteem, to improve their feelings of self-worth, to not look for other people's approval, to go through all the psychological impediments they have that cause them to fall off the wagon, so to speak, in the past, and resort to food as their primary source of solace and comfort. So I'm saying that part of this is being able to reach some people. And I see that the gastric bypass industry shows the failure of our medical approach to be able to impact people with the right nutritional information, but the right psychological and supportive environments to deal with people on a level that can most effectively enable long-term change. And some of my greatest satisfaction is the close relationships I've developed with people who came in here at 390 pounds that have lost 150, 200, that have gotten their health back, that wouldn't even think of eating back the way they used to be, that have got, and some of them have had actually surgery to remove the flaps of skin, but in any case, what I'm saying is some of my greatest pleasure are the relationships of people who've been able to change their lifestyle permanently and stay with this way of eating long term. But it took a lot of effort from a whole team of supportive staff and time to help people make that change so that they can successfully stay with a healthy diet. Some people so what I'm saying is the gastric bypass industry shows somewhat of a failure of the development of their healthcare system, where we're not able to support people adequately to get rid of their food addiction and to train them how enjoyable and how better their life could be if they chose to eat healthfully and maintain a favorable weight for the rest of their life. Thank you.
Steve, I'll just jump in on the question of supplements. I mean, because I have a very supplement-driven practice, but there are clearly times it's completely inappropriate. I have many patients come to me with atrial fibrillation and pathologic status of their heart anatomy, large left atrium, valve disease, and they want to take lumbro kinase from earthworms. Well, I mean, you can't be in my practice and do that because strokes are real and people die, and we have effective drugs that often are insurance covered and have too much evidence-based. But you get into like cholesterol control. I mean, the ACC will comment on complementary approaches to lipid management beyond diet, exercise, weight control, stress management. But you got to hit the same targets. If I'm going to use red yeast rice, I got to still hit an LDL under 70 in somebody with advanced heart disease. You can't sacrifice the data. You can just take a different path. So it actually is pretty rigorous practice to try and do that. And then just for the general vegan, I mean, we've mentioned B12. There are a few brands out, and they're not mine, that are like multivitamins for vegans. It's pretty cool. Little B12, little D, little omega-3. I mean, the industry's responded to basically some science that I think Joel Fuhrman's talked about more than anybody about iodine and selenium, kind of like micronutrients that might be a lower level problem than B12, but there's solutions that are potentially out there. They're not particularly expensive, but we got to be cost sensitive too, because people can end up on hundreds and hundreds of dollars of supplements a month, and you can get a statin or an ACE inhibitor or an ARB, which are name brand, not name brand, but commonly used cardiac drugs for pennies a week if you have some kind of insurance program.
So are you recommending that everyone takes B12, vitamin D, omega-3, iodine, and selenium?
That's never been studied. We do have data that those are common deficiencies. In my practice, they're common in the general population, let alone the vegan population. But yes, if you're not eating seaweed or nori and you're not using Morton salt, you may be low in iodine. These can be measured, but it's not going to be a common practice that measures them. We've talked about omega-3. Vitamin D, we know, and probably 2020 was the year there was more discussion about vitamin D in terms of COVID than there's been about vitamin D in a lot of other conditions. Do we save lives by bringing vitamin D levels of 9 up to 34? I'm not sure we really know that for sure. It's certainly inexpensive and possible through food like mushrooms, but more realistically through pennies a day of a vitamin D, supplement of some kind.
The other issue is that there's some evidence that the zinc status on a plant-based diet is lower exposure, but as people get older, their ability to absorb zinc goes down. And there are evidence to suggest that people taking zinc have lower risk of pneumonia and other infections, especially as they age. And as heart disease and cancer become protected against the risk of developing infectious related death as you age and your immune system decreases. So I think adding zinc to the mix is conservative and is appropriate, especially as we get older. And the other thing I think I wanted to add is to talk about, two things. Number one is that most conventional multivitamins contain folic acid. And I'm a strong advocate against the consumption of folic acid. We should be getting, folate is a different chemical than folic acid. Folic acid is synthetic, petroleum derived, and there's a lot of evidence to suggest that increased risk of prostate and breast cancer. And our diet should be rich in folate from greens and beans anyway. So I'm very cautious in trying to tell people not to take folic acid, vitamin A, beta carotene, and vitamin E, and isolated vitamin E, and that conventional multivitamins contain. And the last thing is this idea about salt. Obviously, Dr. Williams said that salt is salt, whether it comes from the back of the moon, the Rock of Gibraltar, or the Himalayan mountains. It's still sodium, and in high amounts, it has the same effects. And this nonsensical idea that there's healthy salt is just a ridiculous alternative medicine, you could say, scam trying to sell people something. But in any case, what I'm saying right now is that salt causes pro-inflammatory over years of excessive use, causes microvascular hemorrhaging, weakens the endothelial lining of blood vessels, and increases risk of hemorrhagic stroke. And in lots of Asian countries with people with very low cholesterol, who don't eat a lot of meat and bacon and cheese, who have very low rates of heart attack, have very high rates of hemorrhagic stroke. And so what I'm saying right now is you have an increased risk of hemorrhagic stroke with a lower cholesterol, because atherosclerosis may protect some of the fragile vessels in the brain from breaking, because a hemorrhage is a break, not a clot. And what I'm saying is that we have to be very cautious with plant-based eaters, because the risk of hemorrhagic stroke is high and the risk of embolic stroke is low. And the chronic excessive use of sodium, especially from these exotic salts, could still take this plant-based eater and just change their cause of death from one type of stroke or cardiovascular death to another type. And avoiding salt is not just for people who are salt sensitive, not just for people with high blood pressure. Salt has also detrimental effect on gradually weakening the endothelium and lining of the blood vessels, predisposing you to the risk of hemorrhagic stroke. So I'm very concerned about that, those avenues of people trying to sell people sodium for disease prevention, to cause to like a drug, and of course, when you're acclimated to a high salt diet, when you cut the salt out, you temporarily could get fatigue and hyponatremia, because your body's used to putting a lot of salt. The change sometimes has to be gradual. Just like when you go from a low salt diet to a high salt diet, you're not excreting salt. But us individuals who are used to very low salt intake just from natural foods like myself, we don't sweat out sodium, and we're not losing extra minerals when we're exercising. We're not urinating out a lot of minerals and potassium, magnesium with the extra sodium we have to eliminate from all the extra salt and water we have to drink from the high salt diet. So we're much more stable without cramping, without spasm, or we don't have to worry about fluid, when we're exercising or we're playing a hard tennis match or a hard basketball game or sprinting in the heat. We're much more stable because we're not used to excreting a load of minerals in our sweat and our urine. So I'm a strong advocate of a low salt diet. Not that there aren't individuals with problems that require some extra bit of sodium, but that's relatively rare. The vast majority of individuals will do better and live longer, restricting their sodium significantly.
Just a clarification, when you all speak about heart disease and the problems and the causes, are heart disease and stroke the same? Meaning, is everything that, when you talk about when Dr. Esselstyn or someone says a whole food plant-based diet will prevent heart attacks, is it also prevent strokes, or is it not the same?
Well, I was just talking about that, and I just want to make it clear there are two different types of strokes. There's a ischemic or embolic stroke, which is caused by a clot, which has the same risk factors as heart disease. So the answer is yes, heart disease reduction will decrease stroke, will reduce those strokes. But there's another type of strokes that's much higher in Asian countries and high salt populations, and much lower. It's 1/10 of the strokes in this country, and those are called hemorrhagic strokes. It's the breaking of a fragile blood vessel into the brain, which causes a massive bleed, which can be devastating or cause death, which is not caused by meat and cheeseburgers and bacon. And people with very low cholesterols and low animal product diets are still at risk of hemorrhagic stroke if they have a high salt diet. And that's my point, and that's my admonition. And you guys could add to that if you want.
So let me weigh in, just because there's been a lot of fervor over neurologic events in plant-based nutrition lately. And we really have to try to bifurcate this into two issues. So there was an article published just a few days ago, I guess April 8th, so it's a month ago, saying that vegan diets were associated with greater risk of ischemic stroke, 54% increase, didn't reach statistical significance. That's typical because the amount of it is relatively small, and all of these studies are not 30-year outcome studies like Nurses Health or something. Yet it was very clear with statistical significance that the carotid artery intermedial thickness, which would lead to stroke, was actually less. So there's some real confounding or contradictory stuff out there. And the bottom of this is in Journal of Nutrition. Their bottom line, I think I agree with 100%. More high quality research on this topic is needed. Similarly, a few days later, there was a publication from for 2016, that's years, and physicians start a little bit later, but still they're out there. And what they were able to show is that this whole idea of hemorrhagic stroke observed with plant-based diet was actually due to the unhealthy plant-based diet. Now, that was published in the Journal of American College of Cardiology a couple of years ago as well. That is, I know, Stephen, that some of your supporters here are plant-based for non-health reasons and participating in this conference to get more information, but they've been an animal rights person or social vegan or environmental vegan, and those are all wonderful things. But sometimes the vegetarian diet that they're eating is full of fried food and refined grains, sugar sweetened beverages, and the like. And it turns out that the Jack article from a couple of years ago pointed out very clearly that those were more dangerous, that had more cardiac events than even an animal-laden diet, which is hard to imagine that plants could be worse. But if you treat them badly, plants can be worse than actually eating animals. But this Harvard study that was published in Neurology a few days ago was very clear that there is a lower risk of total stroke by people who adhere to a healthful plant-based diet. Once you start talking about an unhealthful plant-based diet, which is actually fairly common, then your hazard ratio for stroke goes up by about 5%. That didn't reach statistical significance. But you end up with, if you take vegetarians as a whole, the hazard ratio was 1.00. But that's because you're mixing two completely different things. People who are doing a healthy diet and people who are not.
And what about seaweed? Since seaweed has salt, but many people have mentioned that we should include it. It has iodine. What are your thoughts on sea vegetables or seaweed? Nori, wakame, kelp, dulse.
There's things out there that are just never going to be commercial successes. Seaweed, natto. I mean, we can pick some other, almost superfood status, but when you get to public palate, public access, we got a long way to go. I'd rather for somebody just eat an apple, grab some edamame, grab some celery. We got a long way to go to get people to eat 5 or more servings of fruit and vegetables a day. But, when you're talking to an elite crowd watching this conference, trying to refine and modify their diet, the greatest diversity, there's the word microbiome coming up again, 20 or more different types of fruit and vegetables a day in your diet, which is really a difficult goal. But nonetheless, adding some sea vegetables would be a great source of nutrients that we don't normally achieve, and a little bit of iodine in the process. So, but again, I don't think I eat sea vegetables once a month, with the exception I have a nice salt-free organic sort of vegetable shake that is kelp based. So I guess I get a little bit there actually.
So it sounds like you all have had a lot of experience and a lot of success when someone comes to you who is overweight, who's got type 2 diabetes, who is trying to prevent heart disease, who's trying to prevent stroke. What has been your experience when people come to you and have cancer or gastrointestinal issues? Have you been successful in helping them? Is that something that's just not lifestyle and nutrition doesn't make a difference? In other words, when people come to see you, instead of saying I have heart disease or obesity, they say I have cancer or I have gastrointestinal issues. What has the success been with a very strong whole food plant-based diet and healthy lifestyle?
I mean, probably Dr. Fuhrman treats more of those patients, either Dr. Williams or I. I'll just say, the data is very strong. Again, the word microbiome. Take a poor, standard, urban American diet, transition for 2 weeks to a plant-based diet, remeasure very advanced parameters of our gut health, our metabolome, our TMAO levels. You can transform your gut into a much healthier gut in 2 weeks by whole plant-based foods and eliminating processed sugar, poor quality fat rich food. So all of us, experience better gut health. And some people actually resolve a lot of clinical issues. But I'll leave, cancer in terms of my comments to probably Dr. Fuhrman.
Yeah, I could say that my recent book, Eat for Life, talks a lot about that. And I've had a lot of experience with cancer patients over the years. And I have to say that that I think the scientific literature supports this concept that the same foods that show maximum protection against getting cancer, that's where we're talking about green cruciferous vegetables and eating scallions and mushrooms, these same, including flax seeds and all these powerful foods that have anti-angiogenic and estrogen favorable effects. And so what I'm saying right now is the same dietary portfolio that prevents cancer has been shown to be effective in the scientific literature at increasing lifespan and preventing recurrence in people who already have cancer. For example, a study on following women who had breast cancer for a decade showed that those with 1/3 of a milligram of lignans from flax seeds or chia seeds every day on the average had a 71% reduced risk of mortality over that 10-year period compared to women not having flax, those lignans in their diet. Likewise, we have lots of studies on people with cancer followed for decades showing that dietary manipulation does afford them an opportunity to live longer and have lower risk of cancer recurrence. So diet does make a big difference when people, it's not just preventative, it extends lifespan with people who have cancer. I gave so many case histories of people who were given 6 months to live with metastatic ovarian cancer and all types of diseases who have now been alive 17 years, 20 years later. And I gave so many of these case histories on my PBS television show that PBS wouldn't let me show them. They cut them out of the show. I had them on the stage and I had the people interviewed going through, they recovered from MS, I got rid of my colon cancer, I got rid of my this cancer, but they pulled it out of the show because they felt it was too unbelievably. And all I'm saying is that why not go all the way when you have a disease? And I think Dr. Williams and Dr. Kahn are saying too, when you have a person who you determine at high risk for heart disease with some measurements, you go out with all the stops and you intervene radically and as aggressively to get them to change their diet and do everything to protect themselves. And I'm saying the same thing is true with any disease. When a person has psoriasis or an early stage cancer, sure, there's lots of cancers that are not going to be impacted Like there are certain cancers that are difficult to get to, or certain cancers that as they become more advanced, you're not going to affect a person's lifespan that much with dietary manipulations. Obviously, the earlier the stage of disease is, hopefully before a person even has cancer, and then they're in a precancerous stage, they're in an early cancerous stage, they're in a moderate, the more the disease advances, the harder it is to expect any predictable or any predictable response. But that doesn't mean the effort should not be there and that we don't see lifespan enhancement and lifespan benefits for people who are using aggressive nutritional interventions who have cancer.
But for the people, when you said that a person got better, was that 1 out of 1,000 or 1 out of 10? Like, how common is it? I mean, when people come to you with cancer and you treat them, does 1 out of 3 get better? Does 1 out of 3,000 get better? Like, how realistic is it? It's okay if it doesn't work, but I just want to set a realistic expectation that we know that when people are 30 pounds overweight and they go on a 20-day water fast, 100% lose weight. If people, have an early stage cancer and they go on a great lifestyle and diet, does 50% get better, or does 1 in 100 or 1 in 1,000?
Well, in about 50 years, I can give you more information about that. It's a joke, but the point I'm making is that, my experience of the last 30 years has been like, take a man with prostate cancer. The lower his PSA and the earlier he comes to you with the early stage of cancer, the more likelihood his PSA is going to come back to normal and he's going to have no residual determination of prostate cancer. But the further it advances and the more advanced he gets, the less you may improve his quality of life and improve his lifespan, but you're not going to be a total curative at that point because the cancer is too advanced. So you can't give a general answer to that question. I could say this. I'm not an oncologist, and I don't primarily see cancer patients. But since I have seen hundreds of cancer patients that have followed my approach over the years and seen an astronomical number of people with long-term benefits that can't be denied, I think I'm astounded by the results, but nowhere could I make any definitive claims or judgment based on percentages or numbers. I could just say my observation of seeing so many individuals who were in an unfortunate situation are able to get well again and to live longer and do much better. And many of them, like I said, including I have a couple of women patients who had metastatic ovarian cancer who have no residual cancer. Now it's been almost one case 15 years and one case more than 20 years. And I have lots of people with you could say early with breast cancers that were in earlier stages that are now living 10, 15, 20 years later and thriving, but I really don't have the studies or data to support anything like that because I was a primary care physician moving from patient to patient, doing the best I can to help them, and not a primary researcher taking in a whole series of cancer patients and seeing the outcomes and spending millions of dollars to try to determine the efficacy. I'd love to see those studies done, and I'd love to be part of that and put my input in. And I do advocate and work with researchers in trying to do studies like that, but obviously the data is not available.
And Steve, I'd just add in, going back to the agreement there is among so much of the conversation here, that there's a single lifestyle that affects so many things, from Dr. Bredesen's brain interest, who's now left. But about 2 months ago, there's a study called PREVEND, and the Journal of American College of Cardiology, Cardio-Oncology. If you follow a heart healthy lifestyle, you don't smoke, you get fit, you eat your vegetables, you monitor your blood pressure, your blood sugar, all the things Dr. Williams talked about, the big 7, your future risk of cancer goes down phenomenally because it's phytonutrients and it's oxidative stress and it's inflammation and it's weight and sleep. And if we will get this group listening and larger groups to follow a heart healthy lifestyle, we will reduce not just heart attacks, but we will reduce cancer risk for sure. But it's not one thing. It's not sprouts, and it's not just green juice. It's trying to manage and juggle day-to-day life with a whole lot of other factors. But do the best you can.
Okay.
So if I can just put a finer point on that, I don't have a practice, but living in the United States, of course, I've had friends who developed cancer, did the chemotherapy, went plant-based, being followed with scans for metastases, and everything looks stable. And as they lose the weight on the plant-based diet, the oncologist tells them, you have to eat meat, and then had the cancer take off. And so I understand that higher cholesterol promotes cancer, more obesity, adipose cells promote cancer, and IGF-1 from animal protein as well. So I'm hoping, Dr. Fuhrman, that people will do prospective randomized trials. There's a little bit of momentum. I've seen this on the MD Anderson website, seen it on Sloan Kettering's website, the Mayo Clinic, that people are supposed to be eating predominantly plants. But they're really talking about prevention. And I hope that they can sort of spread that word throughout the oncology practices so that we don't have to see this astronomical sudden increase in metastases when people start eating animal products, unless these are just a couple of 2 or 3 cases that are anecdotes and they're not really meaningful. The only way to know that is prospective randomized trials.
Yeah, and I agree with you. I think that's what we're going to see. That is that certainly eating healthy, whether people get surgery, chemo, radiation, whatever happens to them, if they stay eating healthier, they have better long-term outcomes than groups that don't. There's no definitive effect for each individual person is going to be different, but at an aggregate scale, if people adopt a very healthy way of eating, they're going to have better long-term outcomes.
Okay,
I'm sure the studies will eventually show that.
Last 4 questions. One, just to make sure we're all clear, talk about plant fats, meaning raw seeds, raw nuts, avocados, and olives, to make sure we're clear on that. I know Dr. Fuhrman covered this during his individual lecture, but let's hear it again here. 2, what do you do when someone comes to you and says, I have gastrointestinal problems, it hurts, everything bothers my stomach? Number 3, what do you think about fermented foods such as raw sauerkraut? And number 4, what are food deserts and why do we have poor people having such bad health outcomes? And what are we doing as a society that's setting it up that people are having such poor access to healthy foods and healthy information, and we're subjecting parts of the population who are poor to guaranteed fast food, high fructose, low quality food that's leading to disastrous health results. Dr. Fuhrman wrote a book, Fast Food Genocide. Dr. Williams is passionate about this. So we'd like to hear about that too. So those 4 questions, if you guys could wrap up with.
So maybe I could start, since healthcare disparities is pretty much what I do all day, every day. And I'm glad that Dr. Fuhrman has pointed it out. There are more fast food restaurants and smaller healthy grocery stores with relatively poor produce. I know I don't generally mention any brands or anything, but there is a movie about this, if people like it. It's about the African-American community called Invisible Vegan, that just outlines all of these issues of food deserts and having to go far away. I do know that, again, I'm not going to mention any brand names, but there is one food chain that I know that everyone is familiar with that's gone into the Inglewood neighborhood and went into Midtown Detroit when I was there. And that, and they changed their pricing structure that everyone used to joke about, and they made it affordable for the inner city people. And that, if that continues, we can get rid of these food deserts and the dependence on fast foods. So 2 other things that I'd like to say. Number 1 is, our government actually spends billions of dollars per year on subsidizing foods or food substances such as high fructose corn syrup and refined flour. And I won't mention a brand, but there's a very popular pastry thing with a catchy name that has 14 different compounds that are food subsidized. That makes it very inexpensive. That makes it affordable for people who are socioeconomically deprived. This really has to end. And I just don't see how we can do this without legislation. The next issue that's more social political is the fact that we don't have the education systems to try and get people the health literacy that they need to make better food choices. There are some places that have gone to a red, yellow, green type of sticker system on foods in their stores. It may make their store really unpopular, but I think that's something that could go a long way, along with the FDA insisting on new labeling to try and get people to understand cholesterol, saturated fat, and sodium. And then the last thing is that my granddaughter, believe it or not, helped me with a project. I was just amazed at the marketing on television. And I was sitting with her and I said, would you mind just watching a bunch of these and writing them down? Now, it turns out that this was on the heels of that article from JACC that talked about healthy versus unhealthy plant-based diet. Part of that article was actually coming up with a scoring system, which I gave to her and said, and so she watched 100 commercials and she scored them all. And the scoring was absolutely atrocious. And the largest negative scores of things that are being marketed were at the fast food restaurants or the fast food, and these franchises. And it turns out that with COVID, they stopped marketing things like airline tickets and rent-a-cars. And they started changing to more food substances, more unhealthy food substances. So that COVID-15 that people talk about, that's going to be with us for a while. That's going to play out in cardiovascular events if we don't get this turned around. So anyway, I'm going to that's the last part that I would talk about, is that it is enhancing our cardiovascular disparities to have these kinds of food substances inundating our communities through marketing.
Joel Kahn is jumping in. I won't speak more about disparities because Dr. Williams is the expert. Fermented foods, 2 thumbs up, but I like to keep it real and simple. And not everybody likes sauerkrauts and can do that. Whole food fats, nuts, olives, avocados. I teach my patients they're fine, not to run away. Most of the scientific data supports that, even in the cardiovascular world, though much of it is actually funded by the avocado industry and the olive industry, but we get the science we get, and we hope it's clean. And I think that was it.
Gastrointestinal issues.
Yeah, gastrointestinal, it's tough. I mean, go slow. Most people can tolerate whole food plant-based diets if they'll just slowly make the transition, and some people can do it overnight. But there is that frustrating group that just does not feel well, and they get wooed back to adding a little animal product back in, but hopefully we can, keep them in the realm of 90% plus. Well, a lot of us do, 100% plant-based.
All right, maybe I'll just add 2 points. One is that I have to say that in looking at the hundreds of studies on nuts and seeds and longevity, cardiovascular death, mortality, and cancer death, that the corroboration between those studies, even if you isolate every one not funded by the nut industry, and most have not been funded by the nut industry, and the corroboration between one study and another is amazing at the degree of consistency among studies to show that these whole food plant-based fats increase lifespan and reduce all-cause mortality, including cancer mortality and cardiovascular mortality. So it's unquestionable that the science that shows that nuts and seeds are a valid addition to the human diet, and even for people with heart disease, most likely taking nuts and seeds out of the diet increases the risk of arrhythmia, sudden cardiac death, and is harmful to them compared to a diet that includes the judicious use of some healthy plant fats like walnuts and hemp seeds. And I think there's a significant amount of evidence that demonstrates that. So number one, there's a false fear that fat is evil and fat's the bad guy. And by the advantage of a vegan or plant-based diet is that it's low in fat. No, it's not true. And is that there's different levels of fat that are acceptable. And of course, we want to continue to recognize the context that body fat is dangerous, and because nuts and seeds are concentrated calories, you can overeat them and you could prevent fat loss, and then that would make the diet unfavorable. But as long as you're moderating your overall calories and you're keeping that within a reasonable framework and you're losing weight and achieving an ideal weight, the nuts and seeds are a wholesome part of a cardioprotective and cardiovascular diet, and there's no data to suggest that that's not true. As far as my comments on food deserts, is that over the years, I really think that we've got to get into reading, writing, arithmetic, and nutritional science as the 4 basic subjects taught in grade schools across the country. That's the most critical knowledge that affects our future, is what we eat and what we, and we have these programs against smoking and against using drugs and against cocaine and saying no to drugs. And we try to indoctrinate our children against becoming drug addicts, but we allow them to become food addicts at the same time. And we support them in our food addiction, and the food and the teachers with the parties and the soccer games and bringing donuts and the support of Halloween and all the celebration around junk food and candy really doesn't respect the fact that eating sweets and candy and commercial baked goods reduces intelligence, creativity, educational achievement, economic opportunity, and is even linked to criminal behavior, in that increase in the highest quintile of consumption of candy in childhood, where people are consuming candy almost daily, have higher risks of criminality and drug abuse later on in life. It's almost like sugar and candy and fast food is the gateway drug to more serious offenses. And we've got to start to put more emphasis into primary education. People say to me, oh, doctors got to learn more about nutrition. And I'm saying, you don't wait to go to a doctor with medical problems at the age of 50 to expect to change your nutrition then, which your whole life of nutrition affects your health and longevity. And we've got to get to people at all ages of life, including right from the start in kindergarten and grade school, and get nutritional education in part of the whole educational process throughout a whole person's educational career. So that's what, it's not going to necessarily happen. There's so much social and negativity, and the political climate in this country is so bad for the climate and bad for future health, or has been. And now we're obviously, hopefully things will change. But even still, there's so much that has to be done differently, and us together, I think, are all fighters and all passionate about changing society and changing America and encouraging people to eat a healthier diet.
If you would each make a 15-second to 20-second closing statement of anything you want to leave us, any final thoughts you want to leave us with.
I'll jump in. I think the greatest secret in medicine is the body has the ability to prevent disease in the first place, let alone to heal disease if present. Thank you.
Thanks, Joel. I would say that the body is a miraculous self-healing machine. And when you optimize the environment for healing, it's incredibly remarkable what can achieved. And diseases that are considered not reversible, including things like asthma and allergies and psoriasis, and these things that fibromyalgia, are reversible. And watching people get well is possible with nutritional excellence and predictable.
So thank you so much for having me. I just want to, sort of add my 2 cents in that we have, we're living in a pandemic twice over, and people are dying from this preferentially because of nutrition factors. That is, the people who get COVID and recover tend to have the healthier microbiome. The people who get COVID and end up hospitalized, ventilated, and dying are the ones who have all of the risk factors that happen from nutrition. That's high cholesterol, hypertension, diabetes, obesity. And so if I had 15 seconds to reach out to everyone in the middle of this dual pandemic, I would say, please, today is the day. You've heard this entire healthcare conference talking about nutrition. Realize that it's the fundamental that can save your life, your family's life, your community, and this country. Thank you.
And could each of you just quickly tell everyone how to get in touch with you, follow up with you, buy your books? Like how do they stay in touch with you?
I have no books or anything like that. If you go on the Rush website, I know I did open my mouth and say I see people online, which is true since COVID. But Rush told me, no, you can't see anybody who's not in a state where you're licensed. So Illinois and Michigan, it'll work out fine. And it's funny how Rush advertises me at Rush Oak Park, which I'm there, a couple times a month. But if you get to there, you'll get to the entire system. And I'm happy to see people who are in either live or in Michiganders or Illinois.
Joel, Kahn, suburban Detroit. I have an active practice, and I have licenses in lots of states. So I invite people to come to see me, but I'm able to do some telehealth too. Thank you.
And if people want to find me, obviously, and get more information about my services, it's drfuhrman.com. And I also answer people's questions and forums on the website that they could as well. So I'm, of course, I spent a lot of time developing delicious recipes and menus to make this so people can use this practically and apply it in their lives if they have diabetes or whatever. So in other words, I'm spending a lot of my time and myself and my staff developing recipes and dietary menus for people to apply this and make it work.
Okay, conference is over. I'd like to unmute everyone so we could thank our speakers.
Thank you, Dr.
Thank you.
Thank you so much.
Thank you so much.
Thank you
so much. That was wonderful.
Information from everyone.
Thank you, everyone.
Thank you.
Appreciate all of you.
Research and clinical